Dr. Umi Azin is a liaison consultant psychiatrist at Hospital Serdang. Dr. Umi Azin again gonna share with you a lecture in terms of behavioral assessment in person with obesity and followed by case discussion. So the same style, just like what Dr. Arif did just now, you can type in the chat box as she shared the case discussion. Okay, Umi, the platform is yours.
Thank you very much, Prof. Nurlaila, for your kind introduction. Thank you, Arif, the first speaker that actually has given us the foundation for us to move on into the second chapter, actually, in the CPG, Management of Obesity, whereby we are going to talk on psychological and behavioral interventions in management of obesity. So I would like first and foremost to express my appreciation to all to the organizing committee and to all the participants who come here on weekend. I think on behalf of the CPG development group, we truly appreciate your interest and to learn what is the latest in the evidence in the CPG to manage obesity, whereby we know obesity is really an endemic, yeah, in our country. So let us see what we have in our CPG. I will guide you through, and I'm sure maybe some of you already download the CPG. So they are, even though the psychological and behavioral chapter is only around 2 to 3 pages, but all the important and the crucial aspects of what we need to know in managing psychological and behavioral interventions in obesity, you can find it in the CPG. Okay, so let us start. Next slide. Okay. Okay, why these psychological and behavioral interventions are very, very important? Right now, we are moving the presenter's view. Can you help? I think the organizing team, can you help to put in the slide, slide presentation view. Okay, thank you very much. Okay, so these are the reasons that we find from research, from systematic review as well, and you can see the level of evidence is very, very high, level 1++, that psychological and behavioral interventions in weight management and obesity is something very, very important that all of us must basically grasp the concept, and it is something that will be the technique are going to be used whether you are providing medications, you are prescribing diet or nutrition or exercise, or even when you talk about going for surgery. So this is something very fundamental. And the reason with psychological and behavioral interventions in weight management is we are now moving not just on the amount of weight loss being lost in whatever weight management program that the patient go into, but we aim to sustainable lifestyle changes. So that is the aim right now. If you look into evidence, we have moved from numbers to sustainable lifestyle changes. And to achieve this, we need lots of psychological and behavioral intervention. And why sustainable lifestyle changes is important? Because it improves self-esteem, it improves health overall, functioning, quality of life, and it is typically used in combination with other intervention, and the result, the outcome, is also greater in terms of weight reduction. Okay, so let us go to the next slide. And behavioral intervention also will aid adherence to the lifestyle modification and also medication by enhancing self-efficacy. Self-efficacy is the mindset or belief and confidence that someone can actually overcome barriers, can cope, can manage. Yeah? So this confidence is something which is very, very important. So only behavioral intervention can enhance this self-efficacy, can provide motivation, because you can prescribe anything, you can ask patient to do anything, but without motivation, especially particularly personal or what we call internal motivation, is hard to sustain behavior. And also because we want patients to do these changes based on what matters to them, based on their values. For example, we might for us doctors, sometimes we may emphasize on our concern of patient having complications, yeah, because of their blood pressures are not controlled, for example, or they start to have a certain illness. But for patients, maybe what matters most is for them to live long enough to see their children growing. So we want to actually bring up this internal motivation based on their values. So that's the reason why behavioral interventions are very important. Okay, so next. So the recommendation in CPG is there is not just one, a behavioral intervention which are evidence-based, but we recommend a multi-component approaches. And these multi-component approaches should be integrated in managing people with obesity. And what are the approaches? One, it starts with the communication itself, a communication that avoids stigmatization, and how we psychoeducate patients so that they understand about their situation, then followed by motivational interviewing to help with their motivation, and then only behavioral strategies, and also psychological intervention. So all these are very, very important that we cannot just jump into behavioral intervention. Like, for example, maybe how to do certain behavior without looking into whether we engage with good communication. We are not the ones stigmatizing patient. They understand about the illness and they have good motivation. Okay, next. So let's look into what it means by enhancing communication and avoid stigmatization. So this is something that you can refer to the CPG. So I hope, because I just bring this so that you can see the CPG together. You know when to look, where to look when you want to refer. So when we talk about enhancing communication and avoidance of stigmatization, again, you can see it is a high level evidence. We must communicate with empathy. And this is very, very important without negative judgment and bias, because most of our patients, they have gone through a lot of discrimination, a lot of stigmatization before they come to sit in front of us. So we must have this mindset that this is someone who have actually maybe have heard. If you just want to give advice, they have heard all the advice. We have to have a different approach. And we want to recognize that obesity has a complex multifactorial etiology. So it's not just something within their voluntary control most of the time. So we want to ask permission, and this is again has been emphasized again and again. So we cannot just terjah and talk about obesity. We want to ask whether they are ready, and we want to acknowledge that we want to validate that they have gone through a lot, and we want to avoid using inappropriate or hurtful words, and also how we want to address them. We don't want to use the word like obese patient, so we want to use less stigmatizing, maybe with management issue or living with obesity rather than an obese person, because an obese person means we label that person as obese, but people living with obesity means we acknowledge he or she is a person and having obesity as part of the problem. So this is something very, very important to start with. Next. Next, how to psychoeducate and then motivate patient. Okay. In psychoeducation, I think we can go next slide. Next slide, please. Okay. In psychoeducation, we want to educate patient that what we are going to do is towards achievable behavioral and psychological goals. That's our aim. We want to improve health, function, and quality of life. So we want to be more holistic rather than talking about just the amount of weight loss. So our psychoeducation must move from just numbers to something wider. And in motivational interviewing, what we talk about motivational interviewing is we want to motivate patients. So how do we motivate? It must be evidence-based. We cannot motivate by, for example, threatening patient. We cannot motivate by giving patient guilt trip, like guilt trip patient. That's not evidence-based. So we want to collaborate with patient, and we have goal, because as I always mention, the usual counseling is not directive. Meaning to say, in usual counseling, you come with whatever patient have, and patient has to make decision. For example, when you do marital counseling, you don't decide that the patient divorce or leave the marriage or stay in the marriage. You are not going to have direction. You are going to facilitate the discussion, and then patient will decide what's best. But for motivational interviewing, the counseling is goal directed. From the very beginning, you know that you are going to help patient to lose weight. It's not a decision that, okay, I want to stay this weight or I want to lose weight. It's already directional. That's why it is goal oriented, but it must be patient centered. It is directional, but you cannot be directive. You cannot direct patient. So you must learn a way how to be directional without directive. So that is what motivational interviewing is all about. And we need skills, and also we need steps. The steps must be followed. Like we need to engage with patient first. We need to focus on one behavior that we want to change. And we need to do lots of evoking so that patient will come out with their reason on why they want to change. And then only we plan. So this is something very, very important. So and this must be according to the flow. Let's say if you plan without engaging, that's not going to work. Or we, for example, we evoke, like we try to understand why they want to change without really focus on what we want to talk about, whether it's you want to talk about exercise or you want to talk about diet. So it's going to be you are going to be stuck. You are going to be overwhelmed. So we need to focus. So these steps need to be followed step by step. Okay, so next. Right. And to do that, we need to understand on what stage patient is. Whether patient is still in pre-contemplation, meaning to say they don't see it is a problem, or they are contemplating. They already know, I need to change, but they have lots of but and excuses, or they are already prepared, or they are already taking some action, or they are in maintenance phase, or they are actually relapsing and wanting to bounce back again. So because the approach will be different. Let's say patient is already in maintenance or action, you don't have to actually evoke. You do have to find reason why they want to change. You can plan. But if let's say patient who are in pre-contemplation or in contemplation and you start planning, it's not going to be helpful for them. So we need to have some kind of clinical assessment, because usually we don't use objective assessment here. You can have some clinical assessment, and the assessment done earlier using the OPQRST will be helpful for you, because you know remedy what they have tried, whether they have tried, they are still maintaining it, or they have tried, they relapsed, or they have tried and right now they feel, no, it won't work. I don't think I want to do anything. They are in contemplation. So usually it's clinical judgment in which stage the patient is in. Okay, so let's look into the next slide. So after you have the idea on which stage patient is in, next slide, we can start the motivational interviewing. Just now I talked about the steps or the process whereby patient you need to go through, engage, focus, evoke, and plan. But here are the technique, the skills. We need these skills for us to be able to do motivational interviewing. And these skills are going to be used, to be utilized throughout all the process. Like we need to be able to be someone who asks lots of open-ended, not close-ended, because that will invite more information, yeah? And more exploration. We must be someone who are able to affirm more, meaning to praise, yeah, to praise and to acknowledge when they are something positive. Can be positive effort, positive attribute, positive, yeah, whatever positive character, yeah, anything positive, not necessarily positive outcome. Even the positive process, we want to be able to affirm that. So this is totally the opposite from criticizing or threatening. Yeah? So threatening and criticizing is not at all in the vocabulary when you want to do motivational interviewing. We want to learn to do lots of affirmation. And then we must be able to do lots of reflection. Reflection is when there is something difficult. We must be able to acknowledge that, yeah, I can see that's difficult. Yeah, I can see this upset you. I can see that you are worried. Must be able to do that rather than the opposite of reflection is we dismiss the emotion and we quickly give advice. For example, we quickly try to solve problem without validating the emotion. And finally, we want to summarize. We want to summarize everything so that patient know that they are being heard. They are being understood, because summarizing basically, we want to check, am I having the correct understanding of your situation? Yeah? Okay. So next. All right. So again, these are the 4 process. I just want to re-emphasize. As you can see, we are going to use OARS. Sometimes the engagement can take a long time, but assessment itself, if done correctly, that is also therapeutic. When you ask OPQRS and you integrate with OARS, yeah, OARS skills, you can engage patient. So it becomes therapeutic. Then you can focus. In focusing, you can ask patient which one that you want to tackle first. Or you can also recommend on your own. But if you want to recommend, it's about using us, tell us. Like, yeah, I think maybe, is it okay for me to suggest something? I think the most important right now is to talk about your medication first before we go into other things. Maybe or we want to talk about your diet. Is it okay because I think this is the most urgent thing. What do you think? So that is what we call as us tell us method, yeah? Because we want to avoid being paternalistic. It's about collaborating with patient. And then evoking is the heart of motivational interviewing, because you can find that engaging, building rapport is there in all consultation. You need to do that. In all counseling, you need to do that. In all talking therapy, you need to do engaging, and you need to focus. You need to have some structure. But evoking is the only thing unique for motivational interviewing, because this is where you want to cultivate the change talk, the reason for change, and you want to soften the sustained talk, the reason why patient want to sustain the current behavior, the excuses. We want to soften that. We want to enhance the reason for change. And then only we plan. And usually we want to use a SMART plan or SMART goals. We are going to talk about that as well. Okay, next. Okay, so once we have the patient's motivation, then only we can strategize with behavioral strategies and also psychological intervention. Next. Yeah. And the first behavioral strategies usually start with goal setting, the SMART goal. Yeah? So this is the first one, because without goal, it's hard. Yeah, it's hard to see the direction. Where are you going? So behavioral strategies improve adherence to lifestyle, and there are lots of behavioral strategies, but goal setting is usually what we do first. And we want a SMART goal, because sometimes we want to check patient's goal, because most of the time patients have either unrealistic goal, yeah, or outcome goal. Unrealistic goal, and then they try their best to achieve, and then they will be frustrated, and then they go back into relapse, and they will be in pre-contemplation. So sometimes not having SMART goal can be dangerous and harmful. That's why we want to check patient's goal, whether it is realistic, and we want it to be behavioral goal. Let's say patient has outcome goal. For example, I want to lose how many kilogram. Remember, we want to move from numbers. So we want to change this outcome goal to behavioral goal. So how are you going to achieve that? Like what are you going to do? What action? So SMART goal is behavioral goal. It needs to be specific, measurable, achievable, realistic, and relevant. And it must be time-based. Like you don't want to make it open, like you are going to do this forever, but every goal need to have a timeline that, okay, I want to try this for 1 month, because that will give an opportunity for us and for the patient to review back. If there are problems, we can solve. If the problem maybe is a bit too high, we can actually revisit the goal. So that will be something more realistic for the patient. Okay, next. Right. And these are what is in the CPG. There are so many behavioral strategies, and among the evidence-based are doing self-monitoring, because you are what you monitor. Let's say you want to manage your hypertension, you need to monitor your blood pressure. So for you to change your behavior, you need to monitor that behavior. If you want to sleep early, you need to understand like how is your sleep pattern. You need to do some monitoring, tidur pukul berapa and so on. How's your mood before you sleep, what you do. And then you start doing the changes, and then you revisit the changes based on your SMART goals. So self-monitoring is an evidence-based behavioral strategies. Stimulus control is also an evidence-based, like you modify the environment, like what you have in your pantry, in your fridge, what you want to buy, because availability of food is something which is a high risk for the eating behavior. And then maybe sometimes you need to do cognitive reframing. So I'll show example later. And sometimes patients come with problem. For example, when they have they have with their goals, but after 1 month they realize it's not easy. They have lots of problem. So you need to help patients solve the problem using ideal techniques. You identify the problem. You basically you really define what the problem is, and then you evaluate what are the options available. You explore what are the options, and you evaluate the pro and cons of the option, and then you choose one, take action, and then you learn from the problem solving. And then relapse prevention is something very, very important, because just now, if you remember, the stage of change, pre-contemplation, contemplation, relapse is part of the stage of change. It's very normal. We want to normalize relapse. In fact, we want to anticipate relapse, and we want to learn from relapse. So each relapse, we want to make it shorten, and we want to basically lengthen. We want to make a relapse shorten. We want to bounce back to not contemplation, to action. We don't want patient to be in contemplation too long. We want they bounce back to action and then lengthen the maintenance phase. But they will relapse again. So every relapse is a learning opportunity. It's very normal. So this is an idea that we need to understand. Okay, next. Okay, I think to the organizer, I think this is not my final the latest slide. I have my case discussion in other slide that I give to the organizer. Maybe we can switch, because we can switch the slide so that I can have the case-based discussion afterwards. But just now what I shared was you can look into, there are so many journal articles that provide evidence and also guidance on using motivational interviewing in a very busy clinic. You can do it. You can do it in, even if you have 15 to 30 minutes, motivational interviewing is something possible. Something that you can do. And actually that is very, very very effective to do motivational interviewing, rather than we just plan for patients who are actually not ready and so on. Okay. So I have this. This is about a 43-year-old school teacher, BMI 36, and having hypertension, pre-diabetes, knee osteoarthritis, and also has had multiple unsuccessful dieting attempts. And from your psychosocial assessments, you find that she has emotional eating, due to work stress, sedentary lifestyle, and she has low self-esteem because actually her weight issues has been long-standing from childhood. Yeah, again, we know that obesity is multifactorial. She experienced lots of weight stigma. Family somehow, she's motivated. The reason, yeah, I want to change because, yeah, I have children. I want to live long to see my children grow, and because of health, the pre-diabetes, the start to have knee pain and so on. Okay, so how do you communicate and psychoeducate patient? When I think this is very common kan, patient macam ni datang jumpa kita. How do we communicate and psychoeducate patient? So I'm going to just let you observe in my case-based discussion, like how we can enhance communication and avoid stigmatization and use person-centered language in dealing with this patient. Okay, so I start with the don't. So I hope everyone can just see and reflect on our practice. So the don't, this is judgmental, stigmatizing, and no empathy. So you can say, Puan, your weight is an issue. You are considered obese already. You really need to control yourself. Okay. And this is why this is stigmatizing, because we are using the word obese. And we talk about, this is just about control. We know obesity is multifactorial. This is like minimizing the issue, like, oh, you cannot control yourself, that's why you're obese, because we don't convey the message that obesity is multifactorial. So patient said, I've tried many diets, doctor. And we say, well, you need to try harder. Losing weight is about eating less and exercise more. So again, this is minimizing, as if obesity is about trying harder. I get stressed with work, and sometimes I eat when I'm overwhelmed. Yeah, everyone is stressed. We need to have more discipline. Again, this is labeling like patient with obesity is not having self-control, need to be more disciplined. This is actually very judgmental. I feel tired all the time. Of course, obese people is easily tired. If you don't do something now, you will end up with diabetes and all sorts of complications. This is threatening. This is actually guilt trip patient. So this is not motivational interviewing, and this is not how we want to communicate. I know, patient said, yeah, you know what to do. You just have to start taking care of yourself. So can you imagine? But this is rampant, I would say. This before, dulu-dulu lah, hopefully, sekarang dah semakin okay. When we were so paternalistic, when we do not know a better way, we have good intention, kan? Selalunya orang yang buat ni, of course, have good intention. You want to help your patient. You want patient to feel that this will motivate patient by telling about all complication. But evidence state it will not work. In fact, it will make patients stop seeing you. They will come back feeling depressed, and feeling depressed or stigmatized is not helpful for behavioral changes. So what are we going to do? We are going to do this. Communication with empathy, non-stigmatizing. So, Puan, can we talk about your weight and a bit more about your health? So you are asking permission. See, you are not using the word obese here. I've tried many diets, doctor. I see. It must be frustrating to lose weight, but later gain weight again. So you validate feelings first, because by you validating, you are stopping yourself from solving patient's problem. So patients feel that they are being heard and understood. I get stressed with work, and sometimes I eat when I'm overwhelmed. Oh, thanks for sharing this with me. And sometimes people doesn't want to be honest, kan? This is something like, yeah, I eat when I stress, something that looks quite maladaptive or bad. So thanks for sharing. And thanks for sharing is an affirmation. You share about this. I appreciate you for sharing this. And many people eat when they are stressed. You are not alone. So you are validating the difficulties. I feel tired all the time. Yeah, that sounds difficult. Feeling tired can make it harder to eat well, stay active, especially you being a teacher. So again, you keep validating. And I know, yes, and I believe you do know. Most people know what they should do. The difficult part is doing when it is stressful, busy, with lots of ups and downs. So you normalize difficulties with empathy. And yes, so the patient, you know that you engage the patient already, right? You don't have to do this alone, but weight issues are related to many factors, such as genetic, lifestyles, stress, but small changes can make a big difference. We can work on this together. So you are not minimizing, not labeling, not judgmental, not threatening. You are conveying the message that obesity is multifactorial and not labeling as low self-control, lack of discipline, or not doing enough. So this is kind of communication that we want to use. Okay. So after you engage patient, how would you integrate motivational interviewing in weight management? So if you remember what we have mentioned just now, what are the skills for uh, motivational interviewing? Boleh letak dalam chat? What are the skills? The skills of motivational interviewing. Tapi saya tak boleh nampak chat sekarang. Kejap ya. Ada orang yang dah jawab ke?
Wait,
Nah,
not yet.
not yet. Apa skills? Satu skills and process. What are the skills for motivational interviewing?
Okay, ada empathy.
Yeah, empathy. Yes, of course, empathy is very important throughout. Is the open-ended. The open-ended. Lagi. Affirmation. Reflection. And summarizing. Yeah. So the mnemonic is OARS. So that's the skill. When you want to do motivational interviewing, you want to ask lots of open-ended, affirm patient, do lots of reflection, and summarize. But the process of motivational interviewing needs to start with engagement, focus. What is the third one? Boleh ingat tak? Dia mungkin term dia is evoking. Yeah? The third one is evoking, and the fourth one is planning. So we are going to look into that. Yeah? So we are going to apply MI using OARS technique and follow the process of MI, engaging, focusing, evoking, and planning. So open-ended, I've just show again this slide. So you are doing MI when you master the skills. You are not doing MI when you are doing the opposite from the skill. The example for open question is, what worries you most about your health right now? So you want to understand, because this will evoke the reason for change. I can see that you care about your health and family. They care walaupun dia belum ambil action kan. So you just want to look into whatever positive that you can affirm, because we don't want to be the one who is criticizing or threatening. And then we reflect. I hear you saying stress makes you eat a lot and you feel disappointed with yourself. It must be hard for you. So reflecting most of the time is about you repeating what the patient say, non-judgmentally, or you name the feelings. So that's what you can do. You basically validate. This is where you need lots of empathy. Tadi kita dapat jawapan kan, empathy. So and then you want to summarize. So these are very, very important, OARS. So there is no motivational interviewing without OARS. Like if you ask close-ended, do you exercise? Have you started your diet? So it will only invite yes or no answer. So patient akan rasa macam being judged lah, like you are being scrutinized rather than being invited to explore their issues. Of course, criticizing, threatening, if you care about your family, you better do something, because being obese can lead to high BP, diabetes, stroke. So we don't want to do this. Minimizing, dismissing, or giving advice too quickly. Next time, when you stress, you must do deep breathing and try not to find something to eat. Not as easy as that. You must validate first. And deep breathing is not the answer for everything. And then you are not summarizing, because when we are not summarizing, we are not giving clarity to patient, and we are not making patients feel he or she being heard and understood well. Okay, so now we want to use all the skills, OARS, engage patient and focus, and then we evoke. And as I mentioned, how to do evoking in a busy clinic, we use important ruler. There are many ways to do evoking, but what you can do in a busy clinic, the tips is use importance ruler and confidence ruler. Okay, so this is the example when we evoke with importance ruler. You can also draw a ruler on a scale from 0 to 10, how important it is for you to make some changes now. Maybe patient akan cakap 7 or 5. Actually, the answer doesn't matter. What matters is the next question that you ask, that you are going to ask, okay, you answer, for example, 7. Kita tak payah tanya dia, why 7 and not 10? Just now you mentioned you want to improve your health. No, we need to answer why the patient did not answer way down. Okay, you answer 7. I wonder why 7 and not 3. Yeah, patient will respond like, or 3, as if it is not important. Of course, it is important. I don't want my health to become worse. That's a strong reason. What else that makes you choose 7 and not 3? I want to live long enough to see my children grow. What else? Then all the reason to change will come from the patient. If you just use importance ruler. So once you have all the answer, you write down and you summarize. So you are using OARS, importance ruler, and then you can evoke the patient's reason for change. So summarizing will become very important because patient will hear again what she already said to you, and listening from someone else what is in their mind is actually therapeutic and very powerful. Okay, so you move on to confidence ruler. And here I want to emphasize that importance ruler and confidence ruler are two different things. Confidence is your whether you are confident to make the changes. You feel it is important, but most of the time, patients have very, very low confidence. So it's totally different, a different ruler. So don't mix this up. So you mentioned after you have all the reason for change, you mentioned that you want to improve your health, blah, 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 blah. So from 0 to 10, how confident are you that you can make some changes? Maybe 4. Usually it's very low because they have tried before and so on. So you can ask, okay, you still have some confidence. It's 4. Why 4 and not 1? Usually, patient will come with their strength. I've tried before, doctor, I've lost, blah, blah, blah. So you want to bring up the strengths and the experience. So you have done that. So we want to learn from that, right? And then we ask, what would be helpful from you to move from 4 to 5? Not too far. When you want to go down, go far. Okay? Why 4 and not 1? But when you want to go up, what can increase your confidence from 4 to 5, not from 4 to 10, because we want small behavioral changes because that is more sustainable. So what would help you to move from 4 to 5? Maybe patient akan cakap, maybe I need to learn more how to do this. Maybe I need to see dietitian. So this is something that can move you to integrating behavioral intervention. So now you engage patient, you already bring up their motivation using motivational interviewing technique that you can do in your basic clinic, and then you want to integrate behavioral intervention. And the first and foremost, when you want to do behavioral intervention, is about making SMART goal, and SMART goal must be behavioral goal. So you must do it collaboratively with the patient. So for example, in this patient specific, I will bring one healthy snack, maybe fruit or unsalted nuts to school. And I'll do during weekdays. I'll start with one snack a day. And this will help me manage stress eating and improve my health. So this behavior is relevant to the goal, the overall goal that we want to achieve. And I will do this for next 2 weeks and I will see whether it works. So this is the example of a SMART goal. Many other SMART goal. Tapi jangan banyak-banyak goal at one time. Usually we allow 2 goals. 1 is okay. Or 2 maximum. I will drink 1 extra glass of plain water during school hours. We want to teach patient how to make SMART goal, like giving patient how to fish. Next time they know already how to make that SMART goals on their own. So you don't have to coach every time. Patient will start to have their own SMART goal. I will walk for 10 minutes after dinner. When I feel stressed, I will pause for 5 minutes. So be mindful. I will switch my phone. And every time you make SMART goal, you are going to ask patient, okay, can you rate yourself? With this goal, how is your confidence level? Dia kata, yeah, I think I'm confident to do this. It's 8. So you 8, okay, all the best, kan? You do your best. We are going to review again. Tapi kalau patient kata, my confidence is 5, then you have to review the goal, make it easier. Because confidence level of 7 and higher is actually will have a better outcome, will predict success rather than making goal tapi the confidence level is actually less than 7. So now you see patient come with you with low confidence 4, but with SMART goal, patient go out from your room with a confidence level of 7 with a SMART goal to do. So that is the start of behavioral changes. Patient will become more motivated and they will know how to handle themselves moving on, because we are not there for the patient all the time. All the behavioral goals are to increase their self-efficacy on how to self-manage their own self. So then you can add on more other like other technique, yeah, depend whether they come with problem or they come in relapse or they need to monitor and so on. And yeah, sometimes you need to do some cognitive reframing. For example, in this follow-up, patient come with in 3 months weight loss 4 kilogram, improve BP, better sleep, improve confidence, feeling more energetic, eating habit is healthier. But some patient may be frustrated. Oh, doctor, I just lose 4 kilogram, but actually I feel better overall, but only 4 kilogram. So you want to know again here, you want to do some cognitive reframing because your aim is for sustainable behavioral changes more than the number on the scale. So you can say to the patient, reframe it. Yeah, losing 4 kilogram is actually healthy. And more importantly, you have a sustainable behavior. Your blood pressure, sleep, everything, confidence have improved. And you know how to make changes moving forward. So that is actually more important for you, because to change behavior is actually much more difficult than to lose how many kilogram, yeah? Because biggest loser you boleh hilang, but you can gain back the weight, yeah? But behavior changes is something which is actually more difficult, but to have some behavior sustainable is actually one of the great achievement that you can achieve. Yeah. So I think with that, I have covered. Yeah. I think maybe I take a different approach whereby I just show how it is being done in real life, so that hopefully all the participants can have more confidence also. I do not know. Maybe I can ask, what is your confidence level right now to be able to do this in your busy clinic? Maybe you can answer that as I end my presentation. Thank you very much.
Right. Thank you very much, Dr. Umi. That is very interesting.